Dr. Saurabh Sharma. I'm here to discuss one question in ophthalmology from the clinical weakness section of the new pattern which is coming nowadays, and surely it is going to come in the near upcoming exams as well. So in these questions, it is clinically based. We should rule out, we should know the concepts well to rule out the options and derive to our best answer. So let us see one question like this. Hazari Lal, a patient, Namaste Hazari Lal ji, a 68-year-old male patient was operated for cataract surgery by phacoemulsification with posterior chamber intraocular implantation, and after 2 days, the major finding which is given is the patient has after 2 days shallow anterior chamber and the intraocular pressure of 38 millimeters. So that is very high intraocular pressure because normal pressure is less than 21 millimeters. And gonioscopic examination shows 360 degrees of angle closure. And they gave a further extra point that multiple iridectomies were done which could not relieve the attack. So this question is a very important question, the complications of cataract surgery, and this question is about the early post-operative cataract surgery in which the patient has shallow anterior chamber and very high intraocular pressure. So shallow anterior chamber and high intraocular pressure after early post-operative cataract surgery, there are three basic differentials. One is after cataract surgery, if there is an intraocular lens and there is addition between the intraocular lens and the iris, that can lead to a pupil block glaucoma. So if there is a pupil block, see if there is an addition between the iris and the intraocular lens, 360 degrees if there is an addition, the aqueous will not be able to go into the anterior chamber. It will push the iris forward, leading to iris bombing. So here it will be shallow anterior chamber, yes, and the intraocular pressure will be very high like in our case. But this pupil block can be relieved with the help of the treatment is iridotomy. By laser iridotomy, if you give, there is an alternative pathway for the aqueous to go into the anterior chamber, and the pupil block glaucoma can be relieved by peripheral iridotomies. So that could not be the answer. Another scenario, sometimes very rare situation after cataract surgery or more common after glaucoma trabeculectomy surgeries, the aqueous can now go into the vitreous. Misdirection into the vitreous. Usually the aqueous go into the posterior chamber. Now it goes into the vitreous. So it will increase the vitreous pressure. So when the vitreous pressure will increase, the entire lens and iris diaphragm will be pushed upwards towards the cornea. Of course, it will cause shallow flat anterior chamber and it will cause very, very high intraocular pressure. So this is also differential of shallow anterior chamber and very high intraocular pressure. But here in the scenario, peripheral iridotomies will not work because the problem is not pupil block. The problem is in vitreous. So you have to take out the vitreous. The treatment is laser hyaloidotomy, other name of vitreous is hyaloid, or vitrectomy. That is a treatment for this scenario. In this, the laser iridotomy will not work. Even after doing multiple iridotomies, this will not work. So mostly this aqueous misdirection or malignant glaucoma. Why malignant? Because it is very difficult to control with the help of drugs or surgery. Very difficult to control by drugs. Vitrectomy has to be done. That's why it is malignant glaucoma. Alright. One more scenario of shallow anterior chamber and high intraocular pressure. It can start as intraoperative. This is retina, choroid and sclera. Between choroid and sclera there is an artery, posterior ciliary artery, short and long. If there is a sudden fluctuation of intraocular pressure intraoperatively, this can rupture and it can cause a blood in the suprachoroidal space. Suprachoroidal hemorrhage can also push the intraocular contents forwards. It can also cause shallow anterior chamber and very high intraocular pressure. It can start intraoperatively and it can continue postoperatively. Alright, so these are the three scenarios, and this is a very poor prognosis. If the intraoperatively, everything can come out of the incision. So intraoperatively you have to close the incision and sclerectomy is usually done. Post-operatively you have to wait for the blood to liquefy. I'll talk about that. So in our, and this you can see there is a hemorrhage, there is an ultrasound B scan, there is a hemorrhage. These are the choroids which is detached. This is the anterior part of the eye. This is posterior part. See, posterior, this is choroid, and there is a blood which is pushing the choroid forwards, leading to choroidal detachment, but hemorrhagic choroidal detachment. So in our case, pupil block glaucoma we have ruled out, and mostly the answer is malignant glaucoma, because even after multiple iridectomies, it could not relieve the attack. Alright, if the question was, if there was iridectomy done and the problem was solved, then the answer would have been pupillary block glaucoma. Okay, now what is this choroidal detachment and phacogenic glaucoma? Phacogenic glaucoma, as the name suggests, phaco means due to lens, and usually the term is phacoantigenic glaucoma. Usually what happens after cataract surgery, if there is a remnant of lens particles left behind, the lens particles can induce a granulomatous inflammatory reaction inside the anterior chamber. So it will lead to a uveitis sort of situation, and that uveitis inflammatory cells can block the trabecular meshwork and cause the intraocular pressure to raise. But here the anterior chamber is not shallow or deep, it is variable. Yes, intraocular pressure will be high, but anterior chamber is variable, it's not shallow. Similarly, there is a word known as phacotoxic glaucoma. Phacotoxic glaucoma is similar to this, but what is the difference between phacotoxic and phacoantigenic? Here the lens particles after cataract surgery or after trauma, lens particles are left behind, and the lens particles can clog the trabecular meshwork and raise the intraocular pressure. But again, it is not related to the anterior chamber depth. So this is also not the answer to the question. Now, choroidal detachment. So choroidal detachment can be hemorrhagic choroidal detachment or serous choroidal detachment. Hemorrhagic choroidal detachment we have already discussed, can be seen after cataract surgery, shallow anterior chamber, very high intraocular pressure. And usually you have to differentiate this by serous choroidal detachment. Now, serous choroidal detachment is more likely due to decrease intraocular pressure. When there is a decrease in intraocular pressure due to any cause, if there is a leakage incision or there is a hypotony, the eye is collapsed. If the eye is collapsed, you can see the choroidal molds all over the periphery of the eye. And in the ultrasound also you can see the choroidal detachment is there. But there is serous detachment that is associated with low intraocular pressure. We have to differentiate serous detachment with hemorrhagic detachment. Low IOP is associated with serous, and high IOP, which I have told you already, is associated with hemorrhagic detachment. Transillumination can be present in serous, but there is no transillumination when there is a blood, and it is a painful because the intraocular pressure is very high, pain is there. It resolves very long time, it liquefies, the blood will liquefy it and resolves very long time. Serous detachment will resolute very quickly, and there will be a vision loss in hemorrhagic detachment, but usually it resolves, the serous detachment resolves without changing the visual acuity. The important point which you have to differentiate is low IOP is associated with serous and hemorrhagic detachment is associated with high intraocular pressure. So here in the question, multiple iridectomies were done, shallow anterior chamber was there, 360 degrees angle was closed, and the pressure was very high. Answer would have been aqueous misdirection or malignant glaucoma. Alright, I believe every question, if you go in a conceptual manner, you will be able to solve the questions. Please go and do your DAMS question bank after your classes for more conceptual analysis of the questions for the upcoming exams. Thank you very much. Best of luck. Best wishes.